Our next speaker at this point, it's my pleasure to introduce Dr. Michael Leonard, faculty member at the Institute for Healthcare Improvement and also physician lead for patient safety at Kaiser Permanente, and also the principal with Pascal Metrics. For the past several years, Dr. Leonard has taught extensively throughout the Kaiser Permanente system and at outside organizations in high-risk areas such as surgery, obstetrics, critical care, and others to enhance safety. At IHI, he's been active in several domains, including the Patient Safety Officer Training Course, Transforming Care at the Bedside, and the Superior Performance Initiative in the United Kingdom. So please join me in welcoming Dr. Leonard.
Alrighty, I'm going to get down and walk around since I do very poorly behind a podium. But I want to talk to you about a couple things. I want to talk to you about quality and safety as a competitive strategy in healthcare, about organizations that really are seeing this as the niche they're going to have, demonstrating superior quality and value in the market. In fact, I just got back from the United Kingdom where we're working with Scotland on a countrywide project, and they are drop dead serious about it. And when you sit in a room and watch the average hand washing rate across the entire country is somewhere between 96 and 98%, and a culture where one physician is willing to turn to another and say, you know, I'm sorry I didn't see you washing your hands as you started to go into that room. You see cultures and organizations that are really going to knock the ball out of the park. And then I'm going to talk to you about which is a nice follow-on to what Orla was talking about in terms of looking at culture within organizations, which is something we do a lot, which allows you to start kind of systematically examining risk. And then if we have time, we'll talk about a little bit of teamwork stuff. So I have kind of this unique privilege that I work in the Kaiser system. I've worked for Kaiser for the last 18 years, and I work in a national position, national risk management. So I get to look around this huge learning lab of almost 9 million patients, 12,000 physicians, 40 to 50,000 nurses, the IHI, and then also outside organizations ranging from very small hospitals to folks you're all familiar with like Duke or Mayo or Sloan Kettering. What's clear to me is the people that are going to win in this game, because the game is now demonstrable quality and value in the market, particularly in a healthcare system that's spending twice per capita what anybody else in the world is, and not exactly hitting stellar outcomes like being 30th in the world in infant mortality, is that the leaders who are really going to be successful, their niche, the place they've decided to compete, is superior quality and value. You look at organizations like Ascension Healthcare. Ann Hendricks, if she was up here, she would put all her clinical data up on the screen for anybody to see, the raw mortality, social inductions and obstetrics, infection rates, et cetera, because their belief is when they're transparent and open with their data, they're going to drive behavior. And leadership is very clearly involved on the ground, modeling the values, saying this is who we are, this is where we're going, this is what we're going to do. It's actually quite profound. So what's the perfect storm we face? Well, the perfect storm we face, which the healthcare economists talk about, and they were talking back in 1994 when Hillary and company was trying to reform American healthcare, and there have been many previous attempts to do that, going back as far as Truman, is that we have three major factors colliding. One is we have an expanding supply of baby boomers who are going to acquire more expensive, higher quality care. The peak of the baby boomers will hit Medicare in the year 2013. We have a shrinking supply of skilled people to deliver that care. We're expected to be 500,000 to 1 million nurses shy in this country in the next 10 years. And then we're a little bit kind of capped in terms of the amount of money or resource that we can pay. So we've got these three really very powerful factors coming together at a time when basically we're moving toward a kind of consumer report scorecard in medicine with hospital compare and the buyers and the government, the regulators, wanting us to define quality and value in the market. You can find lots of evidence that the way we deliver care is very uneven in this country. This is Elizabeth McGlynn's article in the New England Journal 6 years ago, which looked at 9,000 patients across 30 very clear evidence-based interventions, beta blockers and aspirin after a heart attack that have not only improved quality of life, give you a 30% chance of being alive, greater chance a year later, and the chance of an average American getting a clearly indicated medical care was 54%, which in my book equals coin toss. That's not a reliable, safe system. You have organizations like Beth Israel in Boston, where Paul Levy basically decided 2 years ago to not only put all their clinical quality data on the internet, but if you look up in the left-hand column here, you will find that he put their Raw Joint Commission survey findings up there, because he said, this is who we are, this is what we need to improve, this is where we're going, right? And these people are drop dead serious about this, okay? And Paul Levy also, on his blog, revealed to the world they had a wrong site surgery about a year ago before it was revealed by anybody else. That was an interesting cultural event. Medicare has obviously come to the table and said there's things that shouldn't occur in American hospitals that we're not going to pay for, like retained foreign objects, and they're drop dead serious about it. There's now a lot of work, there's national work. Some of you may be familiar with the Global Trigger tool that looks at 60 indicators, like clotting studies like INRs greater than 5, or low glucoses, or return to the operating room unexpectedly. My friend Don Kennerly at Baylor has a $1 million ARC grant to look at this inpatient, outpatient. Got a nice little visit from the Office of the Inspector General about 6 months ago from Health and Human Services. 6% of their patients at Baylor, well, 30% of the patients have a positive trigger. 6% of their patients have their hospitalization adversely affected or lengthened by a positive trigger. And, you know, what was the question the folks from HHS said? How many of these triggers are preventable, possibly or probably? And the answer was about a third of them. So you can see where that's going to go very quickly, that in the next year or two, the feds are going to define some other things that shouldn't occur at American hospitals and decide they don't want to pay for them. The state of Minnesota is now in year 5 of putting their never events, retained foreign objects, wrong site surgery, on the internet. And you can go to the Minnesota Department of Health and you can drill down by event. And not only can you drill down by event, you can look and say, gee, I'm thinking about going to the Mayo Clinic. I'm thinking about going to Regions or Abbott Northwestern or Fairview. And I can go down and find exactly what occurred in that hospital in the prior year in terms of retained foreign objects, you know, serious or fatal medication errors, et cetera, death or disability in a low-risk pregnancy, which guess what, is where most of those occur. So we are moving very quickly. I mean, how many of you have looked at Hospital Compare, which is a very clunky website, but it has all your CMS data on there, and I can tell you time and time again, I can walk into rooms full of physicians and say, do you guys know how often you give antibiotics within 60 minutes of incision, or how often you discontinue them within 24 hours? Get blank looks around the room. And the next slide is click, here it is, this is you. And not only is it you, it's your 2 competitor hospitals within 5 miles, because your data is out there for the world to see. And you can imagine what those conversations sound like. Oh, the data is bad, or gee, we did our homework, but we didn't turn it in. I'm like, you know, here's a secret. Nobody cares. It's out there for the world to see. So you can tell everybody, you know, the dog ate your homework, or, you know, Microsoft crashed your computer, but game over. So let's talk a little bit about culture with safety. And this comes from a book called Leading with Safety by Thomas Krause. He's a very well-known industrial safety person. In fact, NASA calls him up when they blow things up occasionally. And he asks a basic question: why do some organizations do extremely well with safety initiatives and others fail? And the middle bullet is really the bottom line. It's the quality of leadership and it's the organizational culture. And what do effective leaders do? They're very clear on the values and the mission of the organization, and they model them consistently every day. And you look at organizational excellence, whether in healthcare or otherwise, That is the non-negotiable trait. And they continually are defining behaviors and working to improve the organizational culture. And in fact, how are you going to improve the organizational culture unless you can measure it in a meaningful way? Not surprisingly, people who are good at operational safety are good at finance, okay? Not a big surprise. Now what's interesting is when you look at, so the preface to this book is written by this gentleman named Henshaw. And Henshaw, he used to run OSHA. And he says, you know, we deal with 4 types of organizations. We deal with enforcement targets, right? These are the bad actors. And we have some bad actors in this country. How about the Peanut Corporation of America? But they got a bunch of salmonella-laden peanuts, and that's revenue. Send them out the door. Or how about Tenet Healthcare in Redding, California, that had 20 times the rate of coronary angioplasty and cardiac surgery for 4 or 5 years. I mean, if you had a pulse in Redding, California, you got a procedure, and they made millions of dollars until the Feds showed up, and they ended up paying $700 million to basically rectify that. You didn't have to be a rocket scientist to know that if you're doing 20 times the rate of an invasive procedure, that maybe there ought to be some question marks. And those people, they're enforcement targets, right? And frankly, they ought to be. Then there's the second category, the people kind of are, you know, blissfully clueless. It's probably not a good, bad place to live. You know, maybe I wish I could live there sometimes. Category 3 is the people who want to do the right thing, but they're not quite sure how to do that. And then the fourth are people that are very clear where they're going to go, and they're going there. And that's the Dukes, that's the Mayo Clinics, that's the Memorial Hospitals. I mean, there are a number of organizations, and certainly some guys, Centura and others, could fall in that category. So what are the attributes of these people? It's all about behavior. And what they do is they define very simple behaviors that you know, the way I frame this is they have one set of rules that apply from the CEO to the person who cleans the floor. And so if in your hospital, in your organization, you say, well, you know, Fred's special. Fred's kind of a jerk, but Fred's a great doctor. Fred brings us a lot of business. Wrong, right? You cannot be unpleasant, disrespectful, jerk, hard to approach, and be a good doctor. It's really that simple. Or nurse, or leader, or janitor, okay? And a lot of times we make a lot of excuses around that, and the people who don't make excuses around that are the people who have habitual excellence because they hold everybody accountable to one set of rules. And if I go into my nurses, my doctors, and I say, here's how we're going to use SBAR, here's how we're going to play, here's how we're going to do this, and then somebody gets to opt out, I've immediately said to everybody else, I don't care, right? If we're special, we're different, we have multiple sets of rules, wrong. You could, okay, oh, no, absolutely, okay. And it's absolutely key. Look at people like Paul O'Neill. Paul O'Neill, when he ran Alcoa, before he went to the U.S. Treasury, he got himself fired for being impolitic enough to say the Iraq War wasn't going to be cost neutral. I mean, you know, calling a spade, but if you look at this is the worker injury rate at Alcoa Aluminum. Alcoa Aluminum in 1987 injured 1.6% of their workers annually, which was not bad in industrial safety. And when he left, they were injuring 0.12. They had a 93% reduction in workforce in worker injury. They made a lot of money, because their workers believe they care about them. What's your worker injury rate? In American healthcare, it's 3 to 5%, right? So it's 20 or 30 times safer to work with molten metal and big machines than it is to care for patients. But his 3 rules were a complete environment of non-negotiable respect. And the quickest way to get your butt in hot water at Alcoa Aluminum was be a jerk to a coworker. Not surprisingly, that's the quickest way to get your butt in hot water at Southwest Airlines, is be a jerk to a coworker. And if you walk across the street to Starbucks, do you know what their mission statement is? To create an environment of dignity and respect for everyone. Now think about it. Have you ever had anybody be rude to you in a Starbucks? I'm in a lot of those green signs, I'll tell you, and nobody has ever been unpleasant to me. So these people are very clearly defining behaviors. Paul O'Neill, who's done a lot of things in his life, will tell you will never have habitual excellence in an organization unless you do 3 things. Create an environment of non-negotiable respect, give people the tools and flexibility to do the job, and acknowledge it when they do. This is simple but hard, okay? And if you do that well, I mean, again, look at the habitually excellent organizations. This is exactly what they do. So, Amy Edmondson, who's down here in the corner, is really actually a very accomplished and impressive lady from the Harvard Business School. And she coined this term, psychological safety. And here's what psychological safety means. I would feel comfortable 100% of the time asking for help, voicing a concern, saying, I'm not quite sure what's going on here, could you help me? Right? And if you know, as somebody who lives in the world of risk management, what's the thing that gets us in trouble time and time again? Look at obstetrical catastrophes. 1 in 4,000 deliveries in this country. We have a catastrophic birth injury. We've now thankfully moved that to about 1 in 6,000 in the Kaiser system. But 2/3 of those patients are completely healthy when they walk into the hospital. These are low-risk patients who get into trouble not in 5 minutes, a series of communication failures events, usually over several hours. And the lethal mix in this is now somebody at the bedside is concerned about the patient and is hesitant to pick up the phone because the last time they picked up the phone and called that individual, it was an unpleasant experience. And then you hesitate and you wait and you try and fix it yourself, and by the time you don't have any choice but to pick up the phone, you are in serious trouble. This is absolutely key. And if you think of the people you work with and the people you've trained with, you know the people you could always go to and do go to and say, I have a question, I'm not quite sure what's going on here, could you help me? And the reason you do that is because not only are you going to help fix your problem, but they're going to treat you with respect. And you also know the people you tend to avoid because it wasn't too pleasant. And that's dangerous, okay? That's absolutely dangerous. Across 2,000 hospitals in this country, 25 to 40% of nurses have told us on the safety attitude questionnaire they would be hesitant to speak up if they saw a physician making a mistake. I have never seen a clinical unit. We put up obstetrical safety in 36 hospitals, surgical safety coming soon, emergency medicine safety. We have never, zero, had a clinical unit where less than 25% of the nurses said they'd be hesitant to speak up. And I'll show you a slide across the state of Michigan where that correlated with a reduction in central line infections. The Joint Commission realizes this, and you can look at Jerry Hickson's wonderful work from Vanderbilt, because you know what? The people that are jerks account for a whole bunch of malpractice claims too. At Vanderbilt, 6% of those people account for 40% of the claims and 80% of the dollars they pay out. And you want a simple proxy for social behavior? Look at patient complaints. The average number of patient complaints among that cohort was 42. And the literature indicates you have to piss off 50 to 100 patients for everybody who will go through a formal complaint process. So these are like the wrong poster children of an organization. And what's coming out of Joint Commission now is probably leadership accountability for measuring and fixing this, okay? This is dangerous. I can tell you, you want to put the risk managers out of business? Fix the behavior. It's really that simple. So how do we look at attitudes? Well, as you say, medicine's a social experience. You never quite get a second chance to make a first impression. Bill, can you trigger that for me, please?
Patient has a fractured fibula, given mild sedative, so he could be able to go in tomorrow.
Daddy's going to be so excited.
That killed him.
Paging Dr. Palmer. Dr.
All right.
Palmer.
So much for the Presnani scores, huh? So as Orla nicely talked about before, you look at domains or climates when you look at culture. And we're going to look pretty predominantly at teamwork, what's our perception, am I comfortable speaking up, and safety climate. Here's the bottom line. I'd feel comfortable being a patient in this hospital. I've been in hospitals where only 40% of the people who work there agreed with that statement. And I also was in a hospital, the Presbyterian system in Albuquerque last week, where 95% of the people said that. So this is the state of Michigan. You may be familiar with the Keystone work. It's now being migrated to 10 other states. This was a central line infection project done across 103 out of 106 ICUs in the state of Michigan. The state of Michigan has a very concentrated purchasing group called the car industry, that's a little interested in finances over the last 3 or 4 years. And they came to the table and they said, we will support, Blue Cross put $30 million on the table, we will support a concerted effort to reduce central line infections. They had a nurse-physician partnership in every intensive care unit. They had to use a checklist. They had to report the data to the CEOs and to the research group. They did 5 things. This is Sesame Street on steroids. I mean, this is so simple. Wash your hands, glove and gown, use chlorhexidine as soap, don't put it in the groin because it's dirty, and take it out as soon as possible. And if you want to talk about our friends in England, they're working on peripheral IV bundles. Do you actually need an IV? Do a good, maintain the dressing changes appropriately, because that's where they get infected, and take it out as soon as you can. I mean, these people, they're way ahead. So what was the end result of this? 70% reduction in central line infections across an entire state. They saved 1,200 lives and $200 million, right? By like wash your hands, use soap, put it in correctly. Now what's fascinating is Brian Sexton from Hopkins went in and measured safety culture prospectively before they started. The bottom line here, caregivers feel comfortable speaking up if they perceive a problem with patient care. And here's the behavior that got instituted in this project. If I'm putting a central line and I'm not following the rules, the nurse is required to stop me unless it's an emergency. Now that nurse is not going to be out of her mind and stop me unless she knows somebody like me is going to show up very quickly and say, Michael, this is how we play. We play by the rules if you're going to be here. Right? That doesn't exist. Game over. Well, look at this. I'm sorry, the pointer doesn't show up on the screen. If you look at the right-hand side, so the goal is 5 or more months in a year with 0 central line infections. You look at the right third on this, right? Because the left-hand scale is percentage of people comfortable speaking up, right? Strong teamwork climate. You look at the right-hand side of this, where 50 to 80, 90% of the people said, I'd feel comfortable speaking up. 44% of those ICUs were able to achieve 5 or more months. Look at the left-hand side of this, where 21% of those could. And the argument I would make to you, which I believe very profoundly, is when you have the right culture that allows collaboration and effective teamwork, then you can work together on all the kind of things we're talking about, whether it comes to antibiotics, guidelines, evolving standards of care. But if you don't have the social relationships, the chance of doing the work is pretty slim. You can go in and measure things. Look at this. Nursing input is well received in this clinical area. Well, the 80% of the doctors think so, and 40% of the nurses, right? And I was in one, actually, it's on the East Coast, about 2 weeks ago. In the operating room, 90% of the surgeons believed nursing input was great, 80% of the anesthesiologists, and 20% of the nurses, right? That's like a bad marriage, okay? And the beauty of this data is when you get into those cultures that don't feel safe, they're not going to sit in the room and have the conversation. But you can go in the room and say, here's what you said. Now all of a sudden it gets personal. Now think about it. I can walk in a room full of orthopedic surgeons where 1 in 4 of those people, 25% of those surgeons, are at risk of doing a wrong side operation during their career. Look to the right, look to the left. Somebody's in the club. And if I've got half the nurses in that OR who are hesitant to speak up, now we care, right? Now it's getting personal. So let's look at an emergency department. 40% of these people say they'd be hesitant to speak up if they perceived a problem with patient care. Less than half of them say disagreements are resolved appropriately. Not who's right, who's wrong, what is best for the patient, okay? Want to be a patient in this environment? No, you don't. Now you can convert this data into what the psychologists call a heat map, where you actually look at these domains. And the key to this is where it's white, that's an A. Where it's red, it's an F, okay? So ideally, the whole thing would be white. But this is looking at 28 different hospitals in these domains, And when you get to, maybe hospital 15 or 23 on the bottom, that's where you'd want to be a patient. You move up to 22 or 5, that's kind of rolling the dice when you go in the door. So people who run large systems can get very discrete views of the clinical risk within those systems. And then you can drill it down into a given hospital, because one of the things that's key about safety culture is there's a 6-fold variation in units across a hospital. You don't want to measure across a hospital. You want to measure dialysis, the ICU, the operating room, the ED, because you can walk 100 feet down the hall and they'll be great. And you can walk 100 feet the other way and it's a disaster, right, where they don't get along. So care is delivered at a clinical unit, culture exists at a clinical unit level, and this allows me to actually, in a thumbnail, to say, where are the high-performing units, where are the low-performing units in this hospital? If I match them up against the places I know that are really dangerous, like obstetrics, the ICU, the operating room, emergency department, maybe oncology, now I have a map of risk. And then guess what? I can actually look at my own events and say, where are the bombs going off? Because then I can intervene. And that's kind of what it's all about. You can do collaborative maps of clinical units. So this is obstetrics. Okay? Now, if you have big arrows that point both ways, those are healthy relationships. If they're skinny and going one way or non-existent, that's a bad relationship. So if we look at the bottom, we've got charge nurses, we've got OB techs, we've got nurses. It's a love fest, right? I love you, you love me, life is good in L&D, right? And then we get the obstetricians. Well, they're a lot fonder of the nurses than vice versa. And then we got the anesthesiologists. They don't like anybody, right? Say it, I'm in the club. So you can figure out what's happening in this unit pretty quickly. And the reality is you can do this in ICUs. It's fascinating. The nurses will always have big green arrows to everybody, 8 or 9 job categories, respiratory, the person who answers the phone, the pharmacist, etc. And in the high-performing units, everybody's got arrows everywhere. In the poor-performing units that have very low safety culture, the physician will have arrows to 2 people, the nurse and the charge nurse. And they're like, why do I talk to the pharmacist? Why do I talk to the person who answers the phone? I'm like, duh, right? So it's all about social relationships. And the more you can map positive social relationships, medicine's a team sport. I mean, the days of we're smart, do it yourself, pay attention, you'll do it perfectly, which is the way I was trained. Nice marketing slogan, highly unrealistic. You can actually track, and we do this. You can actually train observers and track behaviors over time. Then what you want to do is you want to manage risk, because that's really what healthcare leadership's about, is dynamically managing risk. You can look at 5 buckets in a hospital, which are diagnosis, treatment, obstetrical, ICU, surgical, and that's where the majority of your events are going to come from. And you can track them over time. You can also create grids, and this is what we do, which says, in OB, what are the 3 most common things that happen year after year? You know the bad secret about this? The list is the same every year. And it's a pretty short list of high-risk events that occur year after year after year. But you can come and say, here are the 3 things that happen in OB, particularly across a very large care system. Here are the 3 failures of how it happens, and here are the 3 things we're going to do to fix it so that we can now measure. And what have we seen in Kaiser? We've seen a 45% reduction in adverse events and claims over the last 4 years. We have cut it in half, okay? You don't think that translates to the bottom line? That is a very large positive number. But this is the way you can statistically go at it. Simple stuff. You can look at all the big events that happen in your hospital and you can say, so this is 36 events. This is a big academic hospital. And what they say, in 17 of them, we either had or have something in place to mitigate and fix that. And 11, the circles don't quite overlap. And in 8 of them, we're flying blind because we haven't. So this allows you to target your interventions. So let me talk briefly, I know we're running behind here a little bit, about safe care. 3 things. The social piece, safety culture, teamwork, reliable processes of care. You can't have people trying to figure it out, make it up, remember in a busy, distracted, multitasking environment. You want to say, here's how we give antibiotics every time. Here's how we get that patient to the cath lab every time. And the other piece is a really simple process of learning and improvement. So let's think. I go into an operating room, we do a case, we do a 1-minute debrief at the end of the case. What did we learn? What do we do well? What do we want to do differently the next time? Well, you know, the C-arm for radiology was double booked. So we stood around for 20 minutes at $30 a minute, which happens every day in your hospitals. We didn't have this. We didn't have the right drugs. We didn't have the right equipment. Now we capture it. Now it goes in a database. Now it goes to the OR steering group or leadership, and you fix it. These are the most, you know, you go look at surgery. It's the most expensive high-risk venue in the hospital. And if somebody spent 25 years in operating rooms, I'll tell you, 20–30% of the cases I did, we stood in that room with an avoidable delay, waiting for something we should have had in the first place. And it's not only frustrating, it's hugely expensive, right? And efficiency is going to be the name of the game. Here's my version of effective teamwork and communication, right? You heard a wonderful implementation on SBAR in this. And this is really a distillation of about 30 years of work in other high-risk industries. And I apologize, I took this slide out of order here because I didn't think I was going to get through them all. 4 things, simple but hard. Structured communication, here's how we're going to talk to each other. We have predictability. It closes the loop. Not only situation, here's the punchline, recommendation. What are we going to do? When is that going to happen? Don't leave it open-ended because that's where we get into trouble. Critical language. Ask yourself a very simple question. Do you have one word in your hospital, in your clinic, in your health system? If anybody says it, everything stops. And I would suspect the answer today is probably no. Here's a great term, comes from Minnesota. I just need a little clarity. Right? You can be with a patient, 10 family members, not quite sure what's happening, seen something you don't like. Michael, Dr. Leonard, whatever, I just need a little clarity. And that says, you and I need to stop and talk, take a minute, make sure we're doing the right thing. Because I can tell you, as somebody who's run service lines, chaired a board of directors, time and time again, somebody in that room knows something's going wrong and can't find a way to tell somebody else. So I just need a little clarity. Stop, talk to me, let's make sure we're in the right movie here. My friend Alan Price used to be the chief pilot for Delta in Atlanta. You know what they drum into their thousands of flight crews? If anybody has a concern, anybody, it only means one of 2 things. Either you need to know something or they need to know something. And you always reconcile it. You never blow it off, discount it, say it's not important. Because when people get in different movies, you just open the door for something bad to happen. Psychological safety, it has to feel safe to raise your hand. If I ask you to come to the bedside, you come 100% of the time, and you show up with a good attitude. Because if you show up at the bedside and say, why'd you bother me for this silliness? What's going to happen the next time? We're going to go backwards, right? If we're all concerned about the best interest of the patient, sometimes you got to be able to be wrong. That's called a learning or teachable moment, and effective leadership. All right, so let's look at a small communication failure. Want to cue that up for me, Bill?
Das hier ist mein Sektor. Das hier ist das wichtigste Gerät des Küstenwächters. Das Gerät und das Gerät. Überlebensradar.
Mayday, Mayday. Hello, can you hear us? Can you hear us? Can you... Over. We are sinking. We are sinking.
Hello? This is the German Coast Guard.
We are sinking. We're sinking.
What are you thinking about?
Nothing good. So why do we focus on teamwork? Because the overwhelming, get in a room full of risk managers and ask them, tell me about a serious episode of avoidable harm or death that didn't involve a communication failure. Nobody raises their hand. They all do. We looked at the last 30 catastrophic birth events in our system. 100% of them, the central theme was communication failure. Look at wrong site surgery. We still do this. In the overwhelming majority of times we do it, somebody in the room knows the wrong thing's happening and they don't know how to stop the show. Particularly somebody runs in the room, I'm late, get on with it, right? So why do we need teamwork? Because we work in an extraordinarily complex environment. Human factors people who've looked at various industries will look at healthcare and say, It is far more complicated than anything we've ever seen. Flying airplanes is simple by comparison. Standard equipment, standard training, standard procedure. Airplane's broken, weather's bad, you stay home. We don't have that luxury. We have a lot of interruption, multitasking. Think about what our nurses are doing. Our nurses are doing at least 100 different tasks in 8 hours that average about 3 minutes each, and they're being continually interrupted and distracted. If you wanted to design a system to make mistakes, that's exactly how you design it. They are spending 28% of their time on direct patient care, 50% on paperwork, and 10% on overt waste, okay? And in fact, here's a simple example. I can never remember the name of this, but we put a program in Kaiser that said, maybe nurses shouldn't be interrupted while they're giving medication, right? It's a good idea. So we have like the velvet sash. You get to be, Miss Kaiser or Miss America for the day. You put on the velvet sash, nobody can interrupt you. So what's the predictable behavior that happened very quickly? Nobody take off the sash, right? They're like, life's good when I got the sash on. Why should I take it off? I'm thinking about a medicine. I'm thinking about it, right? So simple stuff. Okay, will you just run this for me? And again, this is a great little example of the complexity of processing information.
This is an awareness test. How many passes does the team in white make?
Go!
The answer is 13. But did you see the moonwalking bear?
Sorry, it's a little dark on that clip, but again, why do you need teamwork? Because lots of times something's going on and we're not seeing it because we're busy and we're task fixated. That's why you want everybody in the movie. The other thing is to have a simple process when you're trying to improve something. So here's a hospital that's trying to implement all 4 pieces of the ventilator bundle. And it's an annotated run chart because you can also see that they got to 100%. And it's really, this is like simple stuff. How do we get the bed up at least 30 degrees, right? And literally, I've had people ask me with a straight face, well, Michael, if the head of the bed's up 30 degrees and the patient slides down and they're flat, do we get credit? I'm like, what about 30 degrees is hard to understand here. So you have hospitals that paint lines on the wall. And if the head of the bed's up 30 degrees, you can't see the yellow line on the wall. Or in Scotland, they put little chains with a little paint piece on it. So if the chain is down by the bed frame, it's at the right height. But the other thing is you can say, here's what we did. Here's the intervention. Here's how we learned and sustained, not we just did a bunch of stuff. So an annotated record that shows improvement is a very powerful device. Patients and families, how do we talk to them? Because you know something? It's kind of all about them. Here's something I'm going to spend 2 minutes on, then we'll finish up quickly here. Health literacy. This is huge. This is absolutely huge. How many of you systematically have awareness, try and evaluate the ability of your patients to understand what you're talking about? Okay? Probably very few of you, maybe close to zero. Right? There are very few places in this country who do this very systematically. Iowa Healthcare is one. So here's why we care. There's 5 levels of health literacy. We're all 5s. HL1. 20% of the American public is HL1. They cannot read the headline of a newspaper, right? HL2, that's 40 to 70% of the American public, particularly like Baltimore. I don't know what it is for Richmond. Baltimore, Washington, 60, 70% of the population. Cannot interpret a bus schedule, cannot interpret a bar graph, cannot interpret a pie chart on the front of USA Today. You look at the educational materials you give to your patients, I would strongly suspect the overwhelming majority are at least 12th grade level. And that's not even allowing for context. And what do we know? I mean, there's a recent study where 85% of the people who walked out of an emergency department when asked, what happened? What do you need to do when you get home? What do you need to do when you get better? 85% could not answer that question. 85%, right? So here's a simple technique. It's called a teach back. Instead of saying, Mrs. Jones, we've talked to this, you understand what we talked about, they'll politely nod their head and they're clueless. Please take a minute and explain it. Tell me how you're going to explain it to your family. Not I'm the teacher, you're the student, take the test. Just take a minute and tell me how you're going to explain it to your family. Let me hear it back in your words. You guys who take care of patients, go back and do this once or twice. You do it for the rest of your career. Because you'll find very quickly they don't understand and they're ashamed, so they hide it, okay? I have a friend, Ada. She's an ICU nurse in Florida. She was telling me a little health literacy story. She said, we had somebody admitted to our intensive care unit 3 times in rapid succession with severe diabetic ketoacidosis. Severe, right? Life-threatening condition. The 3rd time this guy's admitted to the ICU, she said, something's wrong here. She's talking to him, you know, how do you administer your insulin? What did she find out? We taught him how to administer insulin by injecting it into oranges, which we do pretty commonly. He's going home, he's injecting insulin into oranges and eating the oranges. So it took us $100,000 worth of care and 3 trips, right? You know, through the gauntlet to figure that out. It's that simple, okay? So, and again, there's a lot of stuff from the AMA. Great introduction to health literacy kit from the AMA. You can't tell by looking for 30 bucks. We know healthcare is expensive in this country. A young couple who comes in to have a baby, dad's eyes are not exactly on the prize. You want to trigger that for me, Bill?
Keep breathing, sweetie. And just look at all the big, expensive equipment. Whoa, that's a lot of gel. 2 nurses. Wow. 2 nurses, 1 baby. We're actually okay if you want to clock out.
Hello, Maria. I'm Dr. Doherty, the anesthesiologist.
Do you charge by the hour, or how does that work? Keep on breathing, sweetie. Keep on breathing. I don't know why we paid all that money for this classes. Is this something that I could do?
The epidural?
Yeah. Do you need an epidural? I mean, I've got some ibuprofen right here that might... Hello, Tony. Hello, Maria.
Oh!
Your spine.
You're about 5 centimeters
Woo, we're just throwing money away, aren't we? Just throwing it away. Any questions? I've actually got one. Do you guys validate parking?
This is over. You are so dead.
City Pro Financial Guidance, a free service at all Citibank locations.
Anyway, major communication failure. Because I want to finish up here and be respectful of people's time, so let me just run you through a couple of quick things here. You can embed these teamwork behaviors pretty much anywhere. Here's what the Brits do. It's called early warning scoring. They score vital signs. And if you take an abnormal vital sign and you put it in a red or yellow box, you got to go talk to somebody. And you got to tell them that the blood pressure was 60 or, you know, the heart rate was 220 or whatever, because lots of times people record things and we don't connect the dots, okay? You can embed these behaviors in any high-risk area, and believe me, we've done that. Every time somebody walks in a room, whether it's a leadership meeting, whether it's an ICU, whether it's an operating room, you set the tone actively and positively. Here's what we're doing. What do you guys think? Any questions, concerns, ideas? I'd love to hear them. 2 things happen. One is a bi-directional exchange of information, but more importantly, you're lowering the inherent power distance or hierarchy so that people are going to be comfortable speaking up. Knowing the names of the people you work with. Nurses are very good at this. Doctors are not good at it, and it's much easier. I mean, think about your ID cards in your hospitals. Most of them have small font. I would guess half of them are pointed backwards, so you can't read them, right? Exempel in Denver makes double-sided ID cards, so they're pretty hard to turn around backwards, right? So you can actually use them. This is a study that came from some of our friends in the Kaiser system. They observed 300 operations. And the bottom line is when the surgeon walked into that operating room, 1 of 2 things happened in 10 seconds. It was either a good movie or a bad movie. And when somebody came in and said, I'm late, get on with it, it got quiet in the OR for an average of 15 minutes. And when it gets quiet, it gets dangerous. 40% of the cases where they set a negative tone in the room, right, they saw something that could have created risk for the patient, okay? And obviously they were instructed to intervene. You always want to have a plan. As we talked about earlier, handoffs are dangerous. One provider to another, one physical location in a hospital, that's where it's very, very dangerous. Here's something from Marty McCary up at Hopkins. 1 minute briefing in the operating room reduced intraoperative delays 32%. You want to talk about a return on investment? That's millions of dollars. And the surgeon's perception by 82%. The last thing you want to do is go in the room, not have what you need, and be standing around. That's a bad dynamic. Right? There's tools that people can use. You've heard about SBAR, right? I don't need to belabor that. This is a Kaiser program that we can use SBAR at the bedside for handoffs. Lisa Schilling's work, very powerful. And then the whole key, assertion. How do you get people politely, persistently to speak up when they have a concern? Not that we would ever see such uncivilized behavior in the Commonwealth of Virginia, but let me show you a couple of models of crude but effective assertion.
Come on in here, I'll give you a drive. I didn't know. You want a piece of me? Why don't you come out and get you some, huh? Where are you gonna go now? Well, you can't speed up by anybody now. You think you're better than me?
At Suburban, you'll find revolutionary ideas that other dealerships just don't offer. Suburban Auto Group on Highway 26 in Sandy. Trunk monkey pending approval by Attorney General.
All right, back in the trunk.
There you go. You want to cue this one up for me, please? So, lest you think there's no application in healthcare, stay tuned.
Don't worry, okay?
Oh, but I think it's happening.
Now?
Yes, right now. What are we doing? No.
Okay, everything's gonna be okay, all right? Breathe with the monkey.
The Trunk Monkey Pediatric Edition. An innovative idea you'll only find at Suburban Auto Group.
All right, let me show you the one that could save Detroit for those of us with lovely teenage daughters.
Here we are.
I still can't believe my dad let us even touch his new car.
Really?
I think it came with the car. Hey.
Sold.
Wait.
Okay.
The Trunk Monkey Chaperone version. An innovative idea you'll
sold,
only find at Suburban Auto Group.